Hello everyone, welcome to Community Medicine Insight. In this video, we will understand everything about oral polio vaccine. We'll discuss about the types, schedule, mechanism of action of OPV, what is the role of OPV in the pulse polio program, what are the advantages and limitations of this vaccine, and what is the meaning of OPV switch and the difference between vaccine-associated paralytic polio and vaccine-derived poliovirus. And we'll also see in the end what are the frequently asked questions regarding the administration of OPV vaccine. OPV is given for the prevention of poliomyelitis, which is an acute infectious disease caused by the poliovirus. There are three types of poliovirus, 1, 2 and 3. While poliovirus 2 and 3 are being eradicated, only wild poliovirus 1 remains endemic globally. And the only two countries where the wild poliovirus remains endemic are Afghanistan and Pakistan. This disease is transmitted by the fecal-oral route of transmission and mainly affect the children below the age of 5 years, and that leads to the acute flaccid paralysis. Coming to OPV, OPV is a live attenuated Sabin strain which is given orally, and it is a highly heat sensitive vaccine and stabilized by the presence of magnesium chloride. There are three types of polio vaccine: trivalent, bivalent and monovalent. Trivalent consists of all the three strains of OPV, bivalent consists of only type 1 and 3, and monovalent consists of only single type. Trivalent OPV vaccine was used earlier. Now it is being replaced by bivalent OPV vaccine, which is being currently used in the NIS schedule. Monovalent is used only during outbreaks. If we talk about the schedule of OPV in the National Immunization Schedule, it is given at birth, which is known as a 0 dose, and it is to be given within 15 days. Then 3 doses of OPV are given at 6, 10 and 14 weeks along with the pentavalent and rotavirus vaccine. Booster of OPV is given at 16 to 24 months. As the name suggests, oral polio vaccine, it is given by oral route and 2 drops are given. How to give the OPV vaccine? We have to tilt the child back and gently squeeze the cheek, and this will make the mouth open and let the drop fall from the dropper onto the child tongue. What is the purpose of giving OPV 0 dose and why it is also called the 0 dose of the vaccine? Because the dose which we are giving at birth, it is not counted as a primary dose. It is an extra dose which adds to the protection of individual and the community. The purpose is to induce the early gut immunity and interruption of the virus transmission. So when we are giving the vaccine at birth, it serves as a priming dose. This dose fails to induce any protective level of antibody, and it is because of the presence of interfering maternal antibodies and secretory IgA antibody in the breast milk. But this dose is sufficient enough to induce enough memory B cell that can be boosted and to have improved serological responses to the future doses. Improved response to future OPV doses. It is particularly important in endemic and high risk areas. Therefore, the protection from this dose may be partial and short-lived, so it does not replace the OPV 1, 2, 3 doses. What happens when we give the OPV by the oral route? Glial cells, their replication occurs and it reaches to the Pierce patches. After reaching Pierce patches, there occurs the multiplication again and subsequent viremia occurs. So due to this subsequent viremia and secondary multiplication and viremia, virus is spread to the other parts of the body. Virus is spread to other parts of body, and that result in the production of circulating antibody. So these circulating IgG antibody, systemic antibody, these prevent the paralytic polio. Intestinal infection stimulates the production of IgA antibody, which will prevent the infection of wild poliovirus. Thus, this OPV prevents the infection, virus shedding, and community transmission. When the vaccine progeny it is excreted in the feces, the secondary spread occurs to the household contacts and susceptible contacts in the community, and the non-immunized children may also be thus immunized. Therefore, it prevents the community transmission of wild poliovirus. The Pulse Polio Program was launched in the year 1995, and the strategy was to immunize all the children under the age of 5 years with the OPV, irrespective of their previous immunization status. The objective was to interrupt the wild polio virus transmission. Pulse means repeated closely spaced OPV rounds which are sudden and simultaneous. Mass administration of OPV is done. What happens after this? The wild poliovirus needs human gut for the multiplication. Although it may survive outside, but for replication it needs human gut. So since the virus is not able to find a susceptible gut due to mass administration of the vaccine, the virus dies out in the natural environment, and thus this breaks the chain of infection. Coming to the advantages of OPV vaccine. Since it is an oral vaccine, no injection is required. It is easy to administer. There is no need of trained personnel. It induces herd immunity, and it is cost effective. Easy administration and induces herd immunity. It is ideal for mass campaigns. Coming to the disadvantages of OPV vaccine. It is a live attenuated vaccine, so there is a risk of vaccine associated paralytic polio. And there is also risk of circulating vaccine-derived poliovirus because of the mutations in the virus. And it is extremely heat-sensitive vaccine, so maintenance of cold chain is critical during the transportation and during the vaccination session also. Coming to vaccine-associated paralytic polio, the risk is 1 per 2 to 3 million doses. What happens in this? When a child receives OPV vaccine, the weakened virus mutates back slightly, and it can cause paralysis in that individual or in a close contact. What are the features of vaccine-associated paralytic polio? It occurs soon after the administration of OPV, and there is a single isolated case. This is something very important. No further spread in the community, and it can happen despite the good immunization coverage. The case definition of vaccine-associated paralytic polio includes a case of AFP with the residual weakness at 60 days after the onset of symptom, a negative stool sample for wild poliovirus but positive for vaccine virus as examined in the WHO accredited laboratory, and the evaluation and confirmation of the case by an expert committee. The clinical manifestation are same when the person is either affected by the wild polio virus or the vaccine associated paralytic polio. We can only differentiate with the help of laboratory finding, and in the case of wild polio virus, we will find the wild polio virus in the stool sample, and in the case of vaccine associated paralytic polio, we will find the vaccine virus during lab testing. Otherwise, clinically, we will not be able to differentiate that the paralysis is caused by the vaccine virus or the wild polio virus. Coming to the vaccine-derived poliovirus, in this the OPV circulates in the poorly immunized population, and it takes months to years for mutation. It becomes capable of causing paralysis and spreading from person to person. So here key important points are: it occurs in the under-immunized community, it causes multiple cases, it behaves like the wild poliovirus. When it spreads, it is called the circulating vaccine-derived poliovirus. Now we'll summarize the difference between vaccine-associated paralytic polio and vaccine-derived poliovirus. Both are different things. It occurs in a single isolated individual, and in this the virus circulates in the community. So there are multiple cases. Here there is only single cases. In the case of vaccine-associated paralytic polio, there is a recent OPV inversion. But in the case of vaccine-derived poliovirus, there is a prolonged circulation and mutation. Other important difference is that it can occur if the immunization coverage is good, while in the cases of this, it occurs when the immunization coverage is low. So basically, vaccine-associated paralytic polio is an adverse event of the vaccine, while it is an outbreak because of the circulation of vaccine-derived poliovirus in the community. Coming to the cold chain requirements of the vaccine, it is a heat-sensitive vaccine. For long-term storage, it is stored at -20. For field storage, the cold chain requirement is +2 to +8 degrees centigrade. Before administering the vaccine, we have to check the vaccine vial monitor, which captures the cumulative heat exposure of the vaccine. So we must not use the vaccine if the VVM reaches the discard point. Discard point means when the square and the outer circle, their color matches, or the square is darker than the outer circle. In these conditions, we will not use the vaccine. Coming to the contraindications of the vaccine, OPV is a live attenuated vaccine. So it should not be given to the children with the weakened immune system, which can be caused by either due to some disease like HIV or due to some medications like prolonged steroid or the immunosuppressive therapies. Other contraindications include reaction to the previous dose of the vaccine like anaphylaxis or a known severe allergy to any of the vaccine components. What is then OPV switch? The OPV switch refers to the global synchronized withdrawal of type 2 containing OPV, that was trivalent vaccine, and now it is being replaced with the bivalent OPV containing type 1 and 3 poliovirus only. This OPV switch happened in the year 2016, and it is implemented simultaneously by all the countries as it is a part of polio eradication endgame strategy. What was the need of OPV switch? As the wild polio virus 2 was declared eradicated in the year 2015, and the continued use of OPV type 2 became unnecessary. Other important reason was the 90% of the circulating vaccine-derived poliovirus were due to type 2, so the risk outweighed the benefits. Some frequently asked questions regarding the vaccine administration. Can vaccine, especially oral vaccine, be administered to a child with the diarrhea and vomiting? So the answer is yes, the oral vaccine can be given to a child with a mild diarrhea, but if the child has severe diarrhea requiring hospitalization, then we should avoid the oral vaccine. Question is, should a child receive OPV during polio campaigns and routine immunization? So we need to give OPV in the routine immunization also, and the supplemental doses in the pulse polio immunization rounds as well, because it is safe and effective vaccine, and every extra dose means a child gets protection against the polio. OPV is a vaccine which requires multiple doses to achieve full immunity against the polio. How many doses of OPV does a child need before they are being protected? So there is no definite answer, because it depends on the entirely on the child health and the nutrition status. So OPV needs to be administered multiple times to be fully effective.